Alexander, are you okay? We can stop if you're not feeling well.
I've waited my entire life for this moment. I can do this.
Ignoring the warning signs, he stepped onto the ice.
He achieved the performance he had dreamed of his entire life. He believed the hardest part was over. Moments after achieving his lifelong dream, something was terribly wrong. What life-threatening condition could cause these sudden symptoms?
Are you okay? Stay with me!
A patient suddenly develops severe chest pain radiating to the back and then loses consciousness. What life-threatening diagnosis should be at the top of your differential?
Acute aortic dissection is my top diagnosis. I'd also consider acute myocardial infarction, massive pulmonary embolism,
Tensions pneumothorax, and cardiac tamponade. Excellent. Let's evaluate the patient.
Dr. Hee Mun, what's the most important risk factor for aortic dissection?
Overall, hypertension. But in young patients like Alexander, always think of Marfan syndrome. Alexander was born with Marfan syndrome. His weakened elastic tissue slowly enlarged his ascending aorta over many years. An aortic dissection begins with a tear. Blood now travels through two pathways, the true lumen and the false lumen. As normal blood flow decreases, less blood reaches the brachiocephalic artery, reducing blood flow into the right subclavian artery and causing a weaker right arm pulse. Notice where the true lumen is compressed.
What if the compression is at the left subclavian artery instead?
Then the left arm would have the lower blood pressure.
A big difference in blood pressure. That's a red flag, isn't it?
Exactly. In a patient with sudden tearing chest pain, always think about aortic dissection.
How do we confirm the diagnosis?
With an urgent CT angiogram, time is critical.
When would we use echocardiography instead?
If the patient is too unstable for CT, bedside transesophageal echocardiography can rapidly diagnose an aortic dissection.
Can a D-dimer to aortic dissection?
No. A normal D-dimer may help rule it out in low-risk patients, but high suspicion always requires CT angiography.
I can see a thin intimal flap dividing the aorta into two channels. The smaller channel is the true lumen, and the larger channel is the false lumen.
Excellent. Now let's think like a doctor. This CT confirms a Stanford Type A aortic dissection. What should we do next?
5, 4, 3, 2, 1.
Stanford Type A requires emergency surgery. Exactly. Stanford Type A needs emergency surgery.
Why are the treatments different?
Because Stanford Type A is next to the heart. It can quickly cause cardiac tamponade, severe aortic regurgitation, or coronary artery blockage. Type B is farther from the heart, so blood pressure control can often stabilize it.
Why do we give beta blockers first?
They slow the heart and reduce the force of each heartbeat, decreasing stress on the weakened aortic wall.
A patient with aortic dissection was treated as ACS and received thrombolytics.
Why is that dangerous? From the torn aorta, causing cardiac tamponade, shock, and even death.
Think like a doctor. Why can a Type A aortic dissection cause severe aortic regurgitation? You have 5 seconds.
The dissection dilates the aortic root, so the valve leaflets can't close completely.
Exactly. That causes acute aortic regurgitation. Let's do one more. Why can a Type A aortic dissection cause cardiac tamponade? You have 5 seconds.
The dissection ruptures into the pericardial sac, filling it with blood.
Exactly. The heart can't fill, causing obstructive shock and a dangerous drop in blood pressure. This is cardiac tamponade.
Why did Alexander develop an aortic dissection?
Marfan syndrome weakens the aortic wall, causing it to enlarge.
What makes it so weak in Marfan
A
syndrome?
fibrillin 1 mutation makes the wall stretch and tear.
Because Marfan syndrome weakens the elastic fibers in the aortic wall.
It stretches more easily and doesn't recoil normally.
What does fibrillin 1 normally do?
It gives connective tissue strength and aorta stretch and recoil, keeps the eye's lens in place, and supports normal bone growth.
So what happens when the fibrillin 1 gene is mutated?
The connective tissue becomes weak. That's why Alexander developed an enlarged aorta, the tall, long-limbed features of Marfan syndrome.
Should Alexander's family be checked too?
Marfan syndrome is inherited in an autosomal dominant pattern, so first-degree relatives should also be evaluated.
Can Alexander compete in figure skating again?
Probably not at the same competitive level. His greatest victory isn't competing again. It's inspiring the next champion.